Hey everybody, my name is Michelle. I am a nurse practitioner. I get a lot of people that ask me about B12. They think they have a deficiency, they want to treat it, and they want to know how. There's a lot of confusion between the B12 pill or injection. Um, so I just want to clarify some facts about B12 and its function, what it's used for, things like that. So B12, or cobalamin as we know it, is one of the 8 B vitamins. Its function is a production of fuel source, and it makes glucose from carbohydrates. And it also aids in the production of DNA, RNA, as well as maintaining nerve cells. It is one of the water-soluble vitamins. So what that means is that the body metabolizes what it needs, and most of the rest is excreted. There's also folate or folic acid. This works with B12 to make the red blood cells, as well as is involved in compounding immunity and mood. The absorption of B12 occurs primarily in the stomach, and thus it requires hydrochloric acid, which is in the stomach. And the hydrochloric acid primarily separates the protein from the food source, so the B12 from whatever food source it's combined with. In combination with intrinsic factor from the stomach, it also further breaks down B12 and carries it to the body. Normal function of the digestive tract is necessary to prevent the B12 deficiency from happening. The interesting thing about B12 is that it's only naturally occurring in animal products, and otherwise it's synthetic. There are 4 forms of cobalamin, which some people may be pretty familiar with the cyanocobalamin. This is the cheapest form and is man-made. There's another form called methylcobalamin, which is another thing that we see often over the counter if you're actually looking at it. And this is one of the most bioavailable forms of synthetically made cobalamin. But unfortunately, this is not well absorbed when taken orally. Another form is hydroxocobalamin, and this is the most active natural form. And it's the only form from the food, and it's very unstable in a capsule, so this must be injected. This form will decrease nitric oxide levels. For the 4th form, you have adenosylcobalamin, and this also is not stable in a pill form. But this is really important because this is a primary fuel source. This is the mitochondrial form of B12. So if you're looking for more of an energy source, the adenosylcobalamin is going to be the best form for that. Some interesting new studies have surfaced in regards to B12 absorption in intestinal flora. Cobalamin is not made from plants and has to be synthesized, but it's also found to be synthesized by bacteria. It's actually been hypothesized that many species would in fact die without their bacterial symbiosis. For example, an interesting find that I have read about is the cicadas. This type of insect feeds on xylem sap, which has no nutritional source for these insects, and instead they obtain vitamins primarily by the symbiotic development between the insect and the bacteriums. Cobalamin is actually abundant in the large intestines, but there are no absorptive receptors found there. They're only found in the small intestines, which is leading researchers to think that maybe there is a critical absorptive method in the large intestines that we may possibly be missing. The significance of some animals that are called ruminants, these are mammals that will digest or ferment their food in their stomach to then regurgitate and chew again. These types of animals are getting their sources of cobalamin from chewing the food again, and they're reaping all nutritional benefits from the bacteria host rather than just the food source primarily. The human feces have been found to have appreciable quantities of cobalamin, possibly produced by bacteria in the colon, but there are obviously no ways of reabsorbing excretory material unless you're a diehard vegan. But they have found that underdeveloped countries seem to be less commonly faced with B12 deficiencies, and they may be leaning towards the likelihood of fecal contamination of food or water, which is resulting in less incidence of this case. Some common causes of B12 deficiency include medications such as contraceptives, also alcohol use, biguanides, questran, anticonvulsants such as valproic acid and Dilantin. Antibiotics, specifically sulfa drugs, have a high incidence of B12 deficiency, as well as Bactrim and Septrim. Antivirals, proton pump inhibitors such as omeprazole, metformin, nitrous oxide use, and colchicine. Also, some malabsorptive diseases such as Crohn's, parasitic infections, and also, obviously, a vegan diet will result in a possibility of a B12 deficiency. Symptoms of these patients, initially they're going to complain of generalized weakness, maybe some paresthesias. Next, they're going to be complaining of leg stiffness. In late symptoms, they may complain of memory impairment or personality changes, maybe mood changes. As the provider, the signs you want to look for are atrophy of the tongue, also known as atrophic glossitis, as well as ataxia, hyporeflexia, spasticity. They may have cognitive impairment, gait disturbances, depression, psychosis. Gastrointestinal symptoms may include angular cheilitis, jaundice, and anorexia. Their skin may present with hair depigmentation or vitiligo, or even skin hyperpigmentation that's similar to Addison's. And when these patients come in, you want to do some lab work, such as a complete blood count. Maybe look for a peripheral blood smear. You can do a serum B12 as well, but a low serum B12 is poorly specific for a deficiency. And to confirm a low value with an additional testing, you're going to have to do an MMA or a homocysteine level. If suspecting pernicious anemia, there are specific labs. These are going to include an anti-intrinsic factor antibodies, a serum gastrin, a pepsinogen, and also consider an upper endoscopy. This is recommended if pernicious anemia diagnosis is considered. You can also consider a Schilling test, but it's not really readily available in the United States anymore. So in your evaluation process, your step 1 is going to be to obtain a B12 level. Folic acid treatment should never be done until you have done a B12 level. Interpreting the B12 level consists of the numbers. Now, B12 greater than 400 is normal. You would do no further testing. A B12 of 100 to 400, you're going to go to the next step, which is going to be to obtain a secondary B12 deficiency marker. These are going to be your MMA, which is preferred, and this can be falsely elevated in renal insufficiency or dehydration. And also the serum homocysteine can be falsely elevated in folate deficiency, renal insufficiency, levodopa use, and hyperhomocysteinemia. If either level is high, you treat the B12 deficiency. If the levels are normal, then you do no further testing. Now, this is according to the new guidelines. If you proceed to managing B12 deficiency, you would start with 1,000 to 2,000 micrograms orally daily for greater than a month. And they're considering the oral as effective as the injections for replacement and supplementation. As hematopoiesis increases, hypokalemia may occur, so you want to monitor the serum potassium levels when you're replacing B12. Interestingly enough, more than 50% of patients with a B12 deficiency related symptoms will have an incomplete resolution despite treatment. Be sure if your patients are on long-term metformin or antacid use that you're considering B12 supplementation long-term, as well as patients who are over 50 years old or post-gastric bypass.